Hello, everyone. Welcome to today's OR Manager webinar, Why the Health of Surgical Dictionaries Matters, presented by Intelligent Medical Objects. My name is Carrie Shapiro, and I'd like to welcome the attendees and thank our sponsor, Intelligent Medical Objects. Before we get started, I have a few housekeeping comments. Today's session is being recorded and will be available on demand in the OR Manager store. We will take questions at the end of the discussion, and we encourage you to submit your questions in the Q&A tab section on your screen. Your questions will only be viewable by the presenters. If you experience any technical difficulties, please use the chat feature and a webinar technician will come online to help you. And today you will earn 1 CE after attending this webinar and completing the quiz that will be available in your OR Manager account. In today's webinar, the speakers will discuss the importance of a well-maintained surgical dictionary. They will describe the value in having structured vocabularies and discuss how surgical dictionary maintenance impacts financial outcomes. I would now like to introduce our speakers for today's webinar. Luann Montgomery has been a registered nurse for the last 25 years. She has worked in several different areas of healthcare. The majority of those years have been spent in the public health arena, working in women's health. But in 2014, she decided to shift her career to health IT and hasn't looked back since. Luann has been with Intelligent Medical Objects since 2019 as a nurse informaticist, helping staff and customers understand the value that IMO provides. Alex Dawson is a senior product manager at Intelligent Medical Objects and leads their procedure solutions. He has been leading product and engineering teams in a variety of industries for nearly a decade. At IMO, he uses that experience to help ensure IMO delivers value to all levels of healthcare. Alex has led IMO's efforts in surgical scheduling as he has overseen a dramatic increase in awareness about the problems in OR dictionaries and has helped nearly 80 health systems to see dramatic improvements in dictionary health. It is now my pleasure to turn it over to Alex Dawson to get started with today's presentation. Alex?
Thanks, Carrie. As Carrie just said, I'm a product manager at Intelligent Medical Objects and been with IMO now for about 4 years and just really enjoy the opportunity that I get on a daily basis to just really help people with their data and health systems with their data and try to make sense of all of it. Speaking of IMO, just a little bit more about IMO as an organization. So IMO has been the primary driver behind what we term clinical interface terminology. So terminology that's meant to interface with clinicians within EMRs and other healthcare situations. We began in 1994 when there were very few clinicians who were even using electronic medical records. And today we are the premier supplier of clinical interface terminology to the US and general English speaking market, with more than 70% of the acute care facilities, 4,500 hospitals, and over 500,000 daily clinician users in the US alone. We are a healthcare data enablement company. So from clinical documentation to the point of care to even complex approaches to population health management, IMO ensures clinical data integrity and quality, making patient information fit for purpose across healthcare. So our footprint in EHRs power our ability to capture and preserve clinical intent wherever and however data is used. Our primary clients span from individual doctors to physician groups, hospitals and clinics, even large IDNs or integrated delivery networks, inpatient OR, surgical centers, even global EMR providers, health information exchanges, clinical data registries, payers, life sciences companies, really anyone in healthcare. We're helping power their data and helping make sure that it's has high level of integrity and high level of quality. Speaking of high level of data quality, that's one of the reasons we're here today to discuss specifically data related to the operating room. So you probably don't need me to tell you that the operating room is vital to how hospitals need to operate. It's a large amount of the revenue that generally hospitals are making. It's a large amount of the margin that hospitals are able to create. as well as being one of the biggest cost centers in the organization. So as we kind of look at that a little bit more deeper, we have different settings that also need to be thought about. We think about performing surgeries at a hospital. We think about or performing surgeries at an ambulatory surgical center. The effective management of the operating suite in either environment requires a lot of detailed planning. There are so many workflows that are dependent on the data that's within those systems that's managing those services, and you need to understand how to manage that data in order to be most effective, no matter what environment you're working in. So really, first you need to know how many cases are scheduled on a particular day to ensure that you're going to have the capacity, personnel, resources. You need to make sure that you're considering the management of the daily schedule with regards to order in which operations are booked. It can include, taking into consideration patient condition, the type of procedure, time averages for procedure, the availability of specific rooms or equipment. And when you take into all that into consideration, thinking through how those are impacted by your surgical dictionary. Now, when we talk about surgical dictionaries, when you think about healthcare in general, the idea of a surgical dictionary might not be top of mind. But when you put in place everything that a EHR system requires to function, surgical dictionaries are one of the fundamental building blocks that live within the system and make everything work. So a medical dictionary is really just a tool, essentially like a reference table that tells users how clinical documentation links to administrative codes. And clinical documentation is exactly what it sounds like. It's the words and phrases providers use to record a patient's medical history, which is comprised of conditions, diagnoses, procedures, lab orders, medications, and among other things. Conversely, administrative codes are coming from the standardized medical coding systems that are generally required by different regulatory bodies, and those help facilitate tasks such as billing, regulatory reporting, analytics, things of that nature. So the ability to have accurate codes linked onto your surgical dictionary creates a huge opportunity within those dictionaries to assist other workflows. Now, if you don't have proper terminology and you don't have accurate administrative code mappings, sometimes it can be hard to spot that being an actual issue. So some symptoms of an unhealthy dictionary: missing terms. If your physicians or nurses or whoever's interfacing with the system is having a very difficult time finding what they're looking for, you could be straight up missing terms. You could have terms that are ambiguous, that are too broad, or poorly worded, or are using inconsistent verbiage. You might have you're going to have a lot of issues with physicians interfacing with the system itself. You might just have terms that just don't actually meet the need of the healthcare system and for proper documentation. Or you might have, as I mentioned before, you might have code maps that are outdated. Generally, code systems are being updated on a regular basis. And whenever they do an update, they're retiring outdated codes, they're updating descriptions or codes, they're adding new codes. And those new codes might be more appropriate for a term that you had a previous code mapping to. So going through all of that can be a very big challenge. And again, these symptoms are going to be present if your surgical dictionaries are not in a great state. So continuing on that train of thought, if we're talking about the side effects of poor dictionary health, again, you're going to have poor search and select as you're having physicians interface with the system. The absent CPT codes, if you're trying to do prior auth and you're needing to go back and forth with your surgeon to figure out more specifics, and you're doing it a lot longer than you normally would think, that could be a sign that you have absent CPT codes. If your scheduling tends to be kind of close enough where you're trying to ballpark, well, we have a range of outcomes for this surgery, and we're not sure exactly how long it's going to take. So we're just going to ballpark it. That might be a symptom that your dictionary is not in a state that's really useful for scheduling. I already mentioned preference card management, but if you have either missing terms or you have duplicative terms, or the general outline of your dictionary isn't optimized for what you're actually able to do, you might be not maintaining enough preference cards. You might be having duplicative preference cards that could be simplified. You could be maintaining too many. And I already mentioned the time averaging, but just being able to have the ability to figure out how long surgeries are taking, both right now and over time, so that you can put that into your system and create an effective and efficient surgical schedule. So I am going to put up a poll question for you all and would love to get your feedback. So hopefully you're seeing that now. Give you a second to respond before moving on. Okay. All right. Thanks for your responses. Okay, so let's talk about surgical scheduling and how it's impacted by dictionary health. So in order to have a healthy scheduling dictionary, you have to have certain things in place, both short-term and long-term, in order to not just get to healthy dictionary in the short term, but to also maintain that over time. So just to call out a few things, having plain language is really important if you're going to be consistent with how you name things, if you're going to make sure that it makes sense to clinicians, and even have the opportunity to have it make sense to schedulers in some cases. Having a consistent way that you name things, with the approach, things like the approach included, things like like the specific names of where you're going to access. You don't want to have any ambiguity in those names. You want to be able to make sure that they're optimized for what your surgical schedule needs to be. So due to the ever-changing and evolving nature of the perioperative space and really surgical techniques in general, without an effective management strategy, these dictionaries can become outdated very quickly. And so they must start with good governance. If you're going to be adding new surgery names, you're going to be taking requests from surgeons or additional orders, having governance over what gets added and a review process to make sure that it's not duplicative or it's not unnecessarily disjunctive can be a really important thing to make sure that the dictionary stays healthy over time. So now I kind of want to talk a little bit more, now that we've talked about health of the dictionary, some symptoms, I want to talk about some downstream effects of poor dictionary health. So as you kind of see from here, there are multiple categories that need to be considered when you're thinking about the impacts of your dictionary, whether you're trying to report accurately on to different regulatory bodies, to public health initiatives on quality reporting. You need to make sure that your surgical scheduling dictionary has the very specific names of surgeries, make sure that the codes are accurate, and make sure that the schedule is efficient to make sure that reporting is able to be done well. On the reimbursement side, again, you have to have those code mappings as early as possible so that you can have effective prior auths, so that you can have effective billing workflows. There are various programs that Luann is going to get into a little bit later that require you to perform certain actions in order to get reimbursed. if you don't have accurate code mappings and you're not doing that based off of clear clinical names, you're going to have a really hard time getting proper reimbursement in those areas. Same with analytics. If you're going to actually try and improve the overall efficiency of your OR, being able to have accurate and reliable numbers that on how you're performing right now is really important to actually being able to take those next steps. If you're not sure where you're weak, or you're relying on only qualitative feedback in order to improve it, you might miss the mark and you might be missing an obvious place to improve. So making sure that your dictionary is healthy can ensure that your analytics are accurate and able to be pulled at really any time. And then on the qualitative side, being able to have clinicians that feel like the workflow is working for them is also really important. If you're having a lot of back and forth, a lot of churn with your clinicians about the schedule or about what their intent was, or trying to clarify things so that prior auth can be made more efficient, you might be running into issues where your clinicians are not satisfied and they have this impression that it's not working very well for them. And if physicians don't feel like it's working well for them, they might feel like you're also not taking care of the patient very well. And making sure that you're taking care of the clinician and their experience can have a really big impact on how they're feeling about the work that they're doing and about the overall mission for your institution. So that's kind of a high level overview, and I kind of do want to dig a little bit deeper. And for that, I'm going to turn it over to Luann.
Oops. Oh. Thanks, Alex. I appreciate it. So now we're going to talk about some of the things that we can do to kind of make all of this kind of gel together and kind of make it a little bit better. So as they said in the beginning, my name is Luann Montgomery. I've been a nurse for a little bit longer than I'd like to talk about, but I've worked in many different areas. A lot of that has been women's health, and we had our own OR suite, which kind of worked well for us. But a lot of that kind of gelled well at the time. But I've worked with the IMO for about 1.5 years now, and in healthcare informatics for a little over 7.5 years. So we're going to talk about the things that we can do to help make that dictionary cleaner and all the side effects of that. So the first thing we're going to talk about is surgical scheduling. So effective surgical scheduling requires an understanding between what the ordering physician wants and then those tasked with preparing for the surgery. So this communication translation is often really difficult. So schedulers not exactly sure what the surgery is to be scheduled, and then just choosing maybe a close enough procedure. And then that can lead to delays and waste in the OR, and then obviously subsequent insurance denials. And then this can also stem from inadequate governance of that surgical procedure dictionary, like Alex mentioned. And then over time, that dictionary can be full of like similarly named procedures, such as what we see often, a cholecystectomy and then removal of the gallbladder. And then also procedures that are added urgently because that initial search of the procedure did not cover what the intent of the surgeon was. So these duplicative procedures can lead to confusion when scheduling. It can also cause excessive or duplicative preference cards. And then there's a high maintenance burden of all those extra cards. So if you have that dictionary governance policy in place, and it can state exactly how to create new procedures, and then you review what gets added and changed, that can help to pay dividends in helping to streamline that dictionary. And then also regular maintenance of your dictionary is also important. And then even a strong governance policy, sometimes that misses things on occasion. But by regularly ensuring that your list of procedures actually reflects what's actually done at your hospital and what procedures you actually perform, and that you have those CPT code mappings up front and accurate, and then they're done. The CPT codes are up front at the point of scheduling. That can reduce the overhead of those regular preference card reviews. So next we're going to talk about the surgical dictionaries and then the CPT codes. So we've mentioned that the surgical dictionary can contain multiple ways to state the same procedure. This slide is shown here on the left. There's multiple ways to say the same surgery often. So laparoscopic appendectomy, there's conceptual duplicates and duplicative procedures that just end up insidiously over time on the same dictionary. But in the center of the slide, if you add a standardized naming convention, such as always add an action first, that way your procedure names will align in the dictionary, and then your search and selection will become much easier. So once those duplicative terms are exposed, consolidation can take place. Maybe you can inactivate or ignore some of those procedures. And then on the right of the screen, those procedures are all mapped to the appropriate code sets. So surgical scheduling and prior authorization. So pre-authorization of cases with the patient's insurance carrier is essential to receiving proper reimbursement. So most surgeries require insurance authorization, and in some cases the schedulers work on short notice, especially if it's an urgent procedure and they're trying to book it in an already busy OR schedule. So when booking the case, the scheduler must know what the intended procedure or procedures is in order to obtain the insurance pre-authorization efficiently. And it's vital at this point that the workflow that the scheduler has, they need that correct or CPT code or codes in order to ensure the best chance for reimbursement. And incorrectly pre-authorized surgical cases can result in little or even no reimbursement sometimes, especially if those cases are surgical procedures that CMS deems as being an inpatient only. And I may be preaching to the choir here, but CMS has determined that specific surgical procedures, some of those require that the patient have at least a full day of monitoring and recovery time as an inpatient. So if any of those particular procedures are scheduled incorrectly as an outpatient, then the hospital doesn't receive any reimbursement for those procedures. So the rule not only applies to cost related to the surgery itself, but it can also apply to any cost related to that procedure. So if, say, the patient went into the ER and then had other labs or x-rays associated with that stay, it can also apply to those services as well. And then those denies can also be costly to any hospital system, as you can imagine. So preference cards, they present a unique challenge to hospital organizations. Multiple studies have shown that surgery supply and waste and instrument waste can cost hospitals anywhere from, say, $1,000 a case to more than $1 million in overspend annually. Preference cards were actually designed to assist OR staff with the setup of instruments, equipment, and supplies, and then provide data to track cost and patient charges. But also recently it's been noted that what began as the primary source of preference cards, which was for the OR staff, has now become more of a tracking function. So a mechanism for coding and charge capture and billing. So a hospital system may have tens of thousands of preference cards. So usually a good time for a pref card cleanup project is either when a hospital is moving to a new EHR or committing to their surgical scheduling cleanup project. So either way, a healthy surgical dictionary allows for preference card management and evaluation. So you can see where a healthy surgical dictionary is just, it's mandatory for this. Let's see, sorry. So accuracy of scheduling cases. Accurate time averaging and analysis of historical data will provide the insight needed to target the number of daily OR hours required for average surgical day. And this will allow for informed scheduling decisions to improve scheduling efficiency. So if everyone is scheduling the same procedure the same way, then it leads to better time averaging. It also helps with easier preference card management, and then less waste and spend. So it also helps, because of that standardized content, it also helps with any reporting that you may have, whether it's National Center for Patient Safety or HNSN or the National Healthcare Safety Network. So it all becomes much easier with that standardized content. And then maintenance of code maps. Industry standard terminology and code sets have routine content updates by CMS and the AMA. And so specifically for the surgical space, these code sets that we use are CPT-4 codes and the SNOMED codes. So the dictionary content must reflect these changes in order to remain healthy. If the dictionary remains untouched, then the content is considered old or aged. So the lack of updates leads to out-of-date terms and the code maps. So if you're using out-of-date materials, then it can lead to inaccurate updates. So some site personnel think that they're making updates to their dictionaries, but it might be based on information that they just have on hand, or from information provided by unverified third-party vendors, such as a web search or maybe even just a code handbook that they have laying around. So obviously, if their codes are out of date, then they can be inappropriate for prior authorization and billing purposes, and then that can lead to delayed reimbursement or costly denials. And then also CPT codes must be updated annually for the CMS and patient-only codes. So degradation of your dictionary structure. This is what we consider constant dictionary governance and maintenance. Once you have a clean dictionary, it's absolutely necessary that you keep it that way. It's extremely important. So busy staff may simply not have the time in their work week to focus on updating those dictionaries with new content. There may not be a designated person at your facility that can focus on doing that. So when new content comes along, they may not be able to update that in the dictionary. There may not be a designated person responsible for that and maintaining the dictionaries if your hospital's not aware that that's necessary. Or the personnel may not have proper training in updating the dictionary and the maintenance requirements of that. Or you may not have the guidelines or best practices for that. But organizations need to be aware that dictionaries are not a create it and forget it type of thing, that they need updating such for medical, regulatory, and organizational needs. For instance, say you bring on a new service line, or you get a big new shiny piece of equipment in the OR, and that's going to require new procedures to be created. So what you need to decide is who has the authority to create those new procedure terms in your system, and what format will they be created in, and then who's going to apply the appropriate CPT codes. So who will attach the preference cards. And if you have a strong dictionary governance policy, that's going to dictate how exactly to create those new procedures, and then what gets reviewed, and then how they're going to end up in your procedure file. And that's what the governance policy is, and that's key to creating and keeping that clean dictionary. So data enablement and analytics. So once you have that healthy surgical dictionary and accurate and up-to-date code mapping, your workflow is actually your own. So this standardization will allow you to study clinical or operational workflows, whatever outcomes you want to study. Your own metadata will still be there. You can set up QI or QA projects or whatever your facility chooses. So once you have that standardization, whatever you choose to study will be much easier with that standardization. So patient satisfaction, there are lots and lots of reporting metrics around this. Plain language procedure naming in a standardized way actually benefits everyone involved, from the surgeon, the surgeon's office, scheduling, to the OR staff, to the preference card maintenance. The procedures are easier to search and select for scheduling purposes. The surgical schedules are easier to maintain. The block utilization and analytics becomes much easier. And our hope is that this can carry over to each electronic medical record. So it says here clinician burnout is a big thing, and it actually is. It's on the rise. And anything that we can do or that can be done proactively to decrease stress is a win for us. And that's what we hope to obtain and maintain for everyone. So that's actually all I have, and I'd like to kick it back over to Alex.
Yeah, thanks, Luann. So we've kind of covered today a lot of ground, and I'm seeing great questions flow into the chat. So really happy to see that. Hopefully we'll have a good discussion. But just a couple things that we want you all to have as takeaways. So really want to drive home this idea that surgical scheduling dictionaries, even though it can seem like a reference data piece that may or may not need to be made more efficient, it does have a significant impact on nearly every piece of managing an operating room, and so it has a very big impact. And even though it has a very big impact, there's often not a lot of governance over it. At a lot of health systems that we work with, they might have a person working on it. There might be a team of people, but even then, it's really hard to keep it up to date, even with a dedicated team. And so having policies in place or having some kind of a solution in place, something that everybody can buy into across the health system, is really important. And then if you're really thinking through how to improve your efficiency, your reimbursement levels, your OR in general, consider thinking through your surgical dictionaries. They, because of that big impact, that could actually be potentially low-hanging fruit that can really help drive, for example, if you have a large preference card optimization project, starting with your surgical dictionary can make your preference card optimization project that much more effective. Okay. Now into Q&A. I think we got questions flowing in.
Yes, we sure do. Thank you, Alex, and thank you, Luann, for your presentation today and sharing your insight. We're now going to open up for Q&A discussion, and I'd like to remind everyone to submit your questions in the Q&A tab section on your screen, and your questions are only viewable by the presenters. So with that, I'll go ahead and get started. Our first question coming in, why not schedule surgery based on CPT codes? Would this standardize the scheduling or eliminate poor spelling?
Yeah, I can take that. Appreciate the question. We get this quite a bit with sites that are trying to simplify and they're still having challenges with scheduling. there's a couple things about CPT that can make it useful for scheduling, and there's also things about CPT that make it a challenge to use. An example of its usefulness is that you have a single CPT code. If you're scheduling by CPT, you're able to get to a single CPT code to help with prior auth. The CPT has their own naming convention, so you have a standard naming convention, and those things are really great. What can sometimes be a problem is that since CPT's use case is not scheduling, and it's actually more on the billing and reporting side, there can be places where it's not super helpful to schedule by. As an example, there's and I'm not going to remember the exact code. I apologize, but there's a code that's something, remove lesion from head, neck, leg, or foot, and that's going to be a single billing code that's used for all of those different procedures. But those different surgeries could have vastly different specialties, vastly different surgeons, even vastly different time averages, and so. In cases like that, and there are others, CPT can be very tricky to use. If you really trust the churn and back and forth that you have, it can be done, and we've seen sites do that. But we generally don't advise it for reasons like that. It's really more important to have something that the clinician understands that's more specific to the surgery. Than to and then put CPTs on top of that. We generally see sites have a lot more success that way.
And can I add a little bit to that, Alex?
Yeah, go for it.
So can I put on my IMO hat for a minute? So in our product, you can search by CPT code. So there's multiple functionalities that are available. So if it's easier for a surgeon to say, I want these particular CPT codes, you can search by CPT code. And then the question, I think the second part of that question is, it eliminates, there was a question about scheduling and eliminate poor spelling. We also include in our functionality or in our product, misspellings, common misspellings and colloquialisms on purpose, because we want it to be kind of a Google-like search. And we know that everybody can't spell, and sometimes when you're in a hurry, you fat finger things. So we include that in our product just because of that very reason. So I hope that helps answer the question fully.
Thank you, Luann. Okay, our next question coming in. How would you handle a surgeon scheduling multiple procedures during one case?
I'll take that one too. Yeah, so for in these cases, this is another instance where it can be really important to have clear names, because as you're potentially stacking surgery, now there's a couple different cases. You could have like a surgery that's almost always done with another surgery, and so we've seen sites just have one name to account for that combination. But when it comes down to like time averaging, we've seen sites have more success building out the specific procedures that they're going to do, even if they're doing them together, and then having accurate time averages on all of those, so that when you're building the schedule, even if you combine them into one case, even with multiple surgeons, you at least have a foundation to make good decisions about the schedule from. And Luann, I don't know if you had anything you wanted to add on that one.
Just that we do see that commonly. A lot of orthopedic surgeries or spine surgeries, neurosurgeries, we do see that very often. There are surgeries that can be done even for gynecological, a hysterectomy can be done by itself, but it's often done with tubes and ovaries. So we have both those options. You can do it singly, or you can do the TAH-BSO. So we have it both ways. If you see that a spine surgery is done, one way, but it's also this certain surgeon always does it with these other procedures, we can build that surgical procedure with all those procedures that he always does, and then it's available in our content for that way as well. Just knowing that it may just be for for that one service line. So we can do it either way. And just to add a little further to that, if it makes sense, our content has over 65,000 procedure terms. So most likely you're going to find that, just because it's not specific to one facility. But if there is a particular surgery that's not done at, that has not been built, we can always build it out as long as it makes sense clinically, and it follows our editorial content.
Thank you, Luann. We'll go on to our next question. Could a standardized procedure list help with the ability to benchmark efficiency measures internally in my own health system and externally outside of my health system?
Yeah, Luann, you want to actually go back to your the slide you had on analytics? There you go.
Yeah.
Is that the one?
There you go. Yep. Yeah. So when you're talking about building, whether it's internal efficiency measures or externally outside of your system in reporting or whatever the case may be, having clear data that you're starting from, clear and healthy data, is really the foundation for even being able to do that well in the first place. And there are certain metrics that you can put on top of your data to make sure that your data is quality. We've talked about a few of them, but things like making sure that all of your procedures have associated CPT code can even be a really foundational metric to track. What percentage of your dictionary is mapped to CPT? Another one could be, what do you have? What percentage of your dictionary has been reviewed by surgeons? One could be related to time averaging. How readily are you able to create a report of time averages for your surgeries? The speed of being able to produce those reports can be an indication of data quality. So those are just a few little things, but really, just to say it again, really that data is the foundation for being able to do better analytics.
Thank you, Alex. The next question, do you have recommendations for who should be in your governance committee?
Yeah, so I mean, the short answer is every organization is unique. You're going to have different teams, different stakeholders in place that could potentially be involved, and it can often be really tricky to navigate how you create that governance. And what we've typically seen from IMO's perspective is a combination of definitely clinical folks, making sure that the names, that the list of surgeries are consistent with what are able to be performed. But what might not be as obvious are folks from IT that are trying to build that data and might have objectives related to data cleanliness that the clinical team might not be aware of. So having that, representatives from IT can often be really helpful as well. Perioperative nursing leadership, making sure that the nurses are able to have their voice heard at that table can also prevent confusion from taking place when both building and executing on the schedule. And really, there isn't a silver bullet as to who should be on there. And even if you have all of the players at the table, you still might need somebody higher than that can understand the importance of not just clinical terminology, but also its link to the things like analytics and the things like reporting and billing that we've talked about, that can understand that and be a strong ambassador for you as you're trying to undergo these improvement projects.
Thank you, Alex. Let's see, the next one. Do you have any case studies that show improved outcomes with a better procedure list?
We do. IMO has, like we've kind of said at the top of that, or we've worked with over 80 health systems on improving this piece of functionality, and we do have a collection of case studies. I wasn't sure if we were able to do handouts, but I think at the end of this webinar, we'll be able to have some materials that will help folks.
Excellent. Okay. Can you explain in more detail how preference card management can be easier with a cleaned up procedure list?
I can take that one, Alex, if you'd like. So with a cleaned up procedure list, like I said, a lot of times hospitals choose to kind of do the surgery scheduling dictionary first, and then they can see what procedures are attached to which preference cards. And so they can decide which procedures they want to keep, which procedures are duplicative or disjunctive, and then they can decide which procedures or which preference cards are attached to those procedures. Some of them may be different service lines. Some of them may be old procedures that were maybe even developed years ago for a provider or a physician that hasn't worked in the facility for years. Or they may be just for specific hospitals in that hospital system. So if it's an enterprise system, they may have to come together and decide what's the master list. So they can kind of get a better idea of which preference cards they want to keep. So we're not saying that, a procedure list of 15,000 is going to end up being a procedure list of 5,000, but they can take a better look at all those preference cards once they get a clean list and decide which preference cards actually make sense. Does that answer the question, I hope?
Thank you. Thanks, Luann. Alex, do you want to add anything, or I think we have one more question to go on to, and then it looks like who should oversee data governance?
Oh yeah, we kind of talked about this a little earlier, but yeah, I mean, just to say it again, the importance of having a cross-functional team of people with buy-in from hospital leadership can't be overstated. But that even with teams like that, it can still be a very large challenge to make sure that it's up to date and that and measuring how effective it is over time.
Mm-hmm.
And usually we encourage, like when we're doing a cleanup or a surgical dictionary cleanup, that they work with the SMEs in each service line maybe to decide which procedures are going to end up on their final file. And then maybe only one or two, maybe it's a person that's going to enter new surgeries. So one person has that ability to enter new surgeries or new procedures at that facility. So that person may be trained to enter new procedures. And it may be somebody that's in IT, like Alex said earlier. It may be somebody in the surgical suite. It just depends on that facility's structure.
Excellent. Well, thank you, Luann, and thank you, Alex, so much. This has been a really good discussion, and thank you for sharing your insight. So we are nearing the end of our hour, and if you'd like to speak with the presenters offline, please email sales@imohealth.com. As a reminder, today's webinar has been recorded. You will earn 1 CE for completing the quiz that will be available on your OR Manager account. We'll also be including some additional handouts from Intelligent Medical Objects. And so with that, we'd like to thank all of the attendees for participating today and our sponsor, Intelligent Medical Objects. We hope you all have a wonderful Memorial Day weekend, and thank you so much.